Welcome to the COPD Foundation podcast. We bring you insights from leading health professionals, inspiring stories from those living with lung conditions, practical advice, and the latest in lung health research. Be sure to subscribe, follow us on social media, and visit copdfoundation.org. Take action today, breathe better tomorrow. Just a quick note before we jump into our topic. This podcast series was created for educational purposes only and is not a substitute for formal medical advice. Talk to your healthcare provider if you have any questions.
Hello, and welcome to this episode of the COPD Foundation podcast. I am your host, Amanda Atkinson, a registered nurse and an educator at the COPD Foundation. Today, Corinne Young and I will discuss the importance of early diagnosis of COPD and Alpha-1, the timing of referrals to pulmonology, and some practical ways that primary care and pulmonology can work together to create a cohesive care plan for patients.
Hi, my name is Corinne Young. I'm a nurse practitioner in pulmonary and sleep medicine, and I work in Colorado Springs, Colorado. I'm also the president and founder of the Association of Pulmonary Advanced Practice Providers.
Welcome, Corinne. It's so good to have you with us today. We know that statistically, many patients experience a delay in the diagnosis of COPD or Alpha-1, and a diagnostic delay can have significant negative implications for patients, including increased risk of exacerbations and comorbidities. I was reading recently some information from the American Academy of Chest Physicians, where they indicated that research showed that in about 66% of patients with COPD, there is a missed opportunity early on to diagnose their COPD at an earlier stage. That's a very large percentage of patients.
Yeah, there definitely is a delay in diagnosis of COPD in a lot of patients. I think it's because we have a bias of what we think a COPD patient looks like and what their history looks like, right? The dirty little secret about smoking is that not all smokers end up with COPD. It's anywhere between 15 to 25% of smokers actually get COPD. So we also have a little bit of an issue of overdiagnosis. If they're elderly, they have a smoking history, they have any respiratory symptoms, sometimes patients get misdiagnosed with COPD. However, the alternative is a little more dangerous. If we don't diagnose those patients with COPD, time is lung. They're losing lung function. They're missing out on opportunities for treatment early on in their disease state to help improve quality of life and morbidity and mortality outcomes. There's a lot of data out there talking about early intervention with COPD patients in reducing exacerbations and symptoms so that they have better, again, quality of life and reduce mortality when it comes to exacerbations. I think one of the delays in getting those patients diagnosed, again, partially is our bias in understanding what a COPD patient looks like. Of the patients who have been diagnosed with COPD, only 70% of them have a smoking history. So we start to forget about patients who may have occupational exposures, who may have had bad air quality exposures, living in areas with high pollution or smog. A lot of patients who came from third world countries with very bad air quality, cooking with biomass, biofuels. Those patients are definitely at high risk for developing COPD. And then we have our genetic patients and congenital lung disease patients, like Alpha-1 antitrypsin deficiency. Alpha-1, I think, is definitely underdiagnosed. And part of that is, again, a bias that it's a rare disease. We think that it's very rare, and estimates are anywhere between 1 and 3% of COPD patients have Alpha-1 antitrypsin deficiency. So that is a very small number for sure. But when we look at the hundreds of thousands of patients that potentially could have this disorder, when we look at the millions that have COPD, we're definitely missing the mark in identifying those patients. Alpha-1 antitrypsin deficiency, to be screened for it, is not as easy as diagnosing a patient with COPD, which would be a lung function test. It requires genetic testing. And so you have to do either a cheek swab or a finger stick or a whole blood send out to look at their genotyping and then also their Alpha-1 levels. We don't want to just look at levels because we can miss the genotyping. Levels can vary and we can miss a patient if we don't do genotyping. And so I think that's definitely a barrier for getting those patients diagnosed.
You mentioned that time is lung. We really want to identify and diagnose these patients early so that we can get them on the best treatment plan to preserve lung function as long as possible.
Yeah, we definitely want to screen early for COPD because we want to intervene as quickly as possible for those patients. And those interventions could look like smoking cessation, which I know we're doing regardless if they have COPD or not, but we know patients with COPD who continue to smoke lose more lung function faster than they should, than a patient who doesn't have COPD and is actively smoking. They also are going to be patients that we want to be a little more aggressive with discussing vaccinations, which are such a hot topic now after COVID. They're difficult discussions to have with your patients, but there are very specific respiratory vaccinations that these patients really should have to improve their long-term outcomes. Getting these patients into pulmonary rehab, you can only qualify them through insurance to get into pulmonary rehab with a diagnosis of COPD. So if they've not yet been diagnosed or screened for it, they don't have access to that resource for them. And we know patients who complete pulmonary rehab have fewer hospital admissions, better quality of life scores, and reduced mortality. So those are great options for those patients. Also, we're trying to intervene earlier in COPD patients to discuss newer interventions such as endobronchial valves for patients. Oftentimes, this is not thought of until patients are end stage or pending transplant, as sometimes a bridge to transplant. But earlier on in the disease, it can improve patient quality of life and function scores so that they can do more activities, sometimes even, continue to work. A lot of these patients, unfortunately, their lung function becomes so severe, they do end up having to quit their jobs because they just physically cannot keep up with them, unfortunately. So we want to intervene as quickly as possible to kind of help these patients with those access to interventions and care.
Typically, we'd expect identification of COPD and Alpha-1 patients to begin with their primary care providers, as they've had the earliest interaction with patients. The best practice guidelines for screening and diagnosis of COPD and Alpha-1 are very well laid out in the literature. With those guidelines in place, we'd expect to see earlier identification of patients and not such a long diagnostic delay. Do you have any insights on overcoming barriers that providers might face in identifying and diagnosing patients?
So there are some great guidelines out there to help with diagnosis of COPD. The GOLD recommendations are the gold standard, if you will, for all of us working in pulmonary medicine that we go to look at how do we manage, diagnose, and help these patients with COPD. So GOLD is a great resource. They update yearly generally, so you do have to keep up with the updates. As far as Alpha-1 antitrypsin deficiency diagnosis, the American Thoracic Society actually put out a great guideline of how to diagnose those patients. And the summary of it basically is that if you have a patient with any type of obstruction on their pulmonary function testing, regardless of their smoking history, emphysema, regardless of their smoking history, a family history of Alpha-1 antitrypsin deficiency, or patients who have bronchiectasis should be screened for Alpha-1 antitrypsin deficiency. I imagine the biggest barrier in primary care would be workflow. The demand on primary care is so high to see such a large volume of patients with such a large breadth of conditions. And oftentimes, Alpha-1 could just not be addressed or front of mind in primary care for sure. We have test kits that are given to us for free, and it's free for the patient through a lot of the Alpha-1 organizations will supply those for you. Now patients can directly request them to be sent to their own home to do a cheek swab and send away. Some of the over-the-counter genetic testing to look at your genealogy. There's one on the market that actually does look for Alpha-1 now. So we do actually get referrals from patients who've screened themselves and have identified that they've had this gene, and then they come to see us in pulmonary. If you send a patient to a commercial lab for Alpha-1 testing, it can be pricey. It can be very expensive. So making sure that primary care understands that there is this free testing option that their patients and their clinics can get so that they can screen patients for free in their office is definitely helpful. And then having the kits right there in your room, definitely helps remind you when you see them. Patients are getting savvy. They're reading a lot more material. A lot of times once they hear they have COPD, they'll go online and do their own research, and often will find information about Alpha-1, which then I think also helps primary care reach towards trying to make sure that they've screened the patient for that.
As providers, we understand the importance of a strong multidisciplinary team in order to provide the best patient care. You mentioned earlier the high volume and workload that many primary care providers face. As you wrap up our discussion today, do you have any thoughts for our listeners on timing of referrals to pulmonology?
I would say working in pulmonary these last 20 years, the majority of the COPD patients that I see are because they were admitted to the hospital under our service for a COPD exacerbation, or their symptoms have become unmanageable to the point that primary care is sending them on to us because they've just reached a stage where they feel like they don't know what else to do for that patient. And that is fine. We love those patients. There's a lot we can do for them. However, we would love to see them sooner in pulmonary. And I know oftentimes the feedback that I'll get from primary care is that we know how busy you are. We know how booked out you are in pulmonary. We feel like we can manage these patients with early disease of COPD. And they absolutely do a great job of managing those patients, but we'd still like to see them. We'd still like to know them before they're in trouble, right? So if we see them, we go through everything and say, you know what, your primary care is doing a great job of managing your COPD. I would like to see you yearly with lung function, or I would like to see you if you start having X, Y, or Z symptoms, or, you look like you're close to being a candidate for pulmonary valves. Here's some information on it. If you're interested in pursuing that further, I'd like to see you back and start that workup, whatever it might be. But we're spending our entire visit time with the patient only addressing their COPD, which I know primary care, when the patient comes in, they're addressing so many other things. It's very hard for them to have a dedicated COPD visit with that patient, talking about, again, vaccinations, activity level, doing COPD assessment testing, doing their lung function testing, assessing them. Are they a candidate for maybe a trial that's in our area? Lots of different medications and therapies are coming down the pike in COPD, which is very exciting. We have more therapies than we've ever had for COPD patients. And I know that's also a lot to keep up with in primary care because they have to keep up with everything. And so we're happy to see them to really fine tune those patients and happy to send them back to primary care with explanations of please send them back if they're having any of these issues. But we would always love to see them because there is so much changing in the world of treating and managing COPD patients. So it's never too early for you to send them to us. We try to get that word out to primary care, but again, it's so difficult because they are so busy. They are seeing such a large volume of patient and breadth of disease states. But we hope that we can partner with our primary care partners and let them know that we would love to see them at any point.
Thank you, everyone, for joining us today on the COPD Foundation podcast, and to Corinne for sharing such valuable insights on the importance of early diagnosis and the timing of collaboration between primary care and pulmonology. Remember, timely screening, accurate diagnosis, and early intervention can dramatically improve outcomes for patients. Start the conversation early and partner with pulmonology where appropriate. Take action today so your patients can breathe better tomorrow. To learn more about COPD and Alpha-1, visit the COPD Foundation at www.copdfoundation.org.
Thank you for tuning into the COPD Foundation podcast. And remember, whether you're managing a chronic lung condition, providing support to those who are, or just want to learn more about lung health, the COPD Foundation is here to support you. Be sure to subscribe to this podcast and follow us on social media. Take action today, breathe better tomorrow.